So, hi everyone, I'm Ravindra, the founder and CEO of the Asian Network, and I will be your moderator for these sessions. The Future of Health Innovation in Asia Virtual Conference is a joint event by the Asian Network and AREA, the Economic Research Institute for ASEAN and East Asia. Welcome to our third session on women health. At the end of our panel discussion, we will have a Q&A session, so please feel free to write your questions in the chat box. For the opening remarks, we have the honor to have Mrs. Shabnam Kazmi, CEO of Asellus Venture.
Hello, and welcome to this panel on women's health at the Asian Network's conference on the future of healthcare in Asia. I'm Shabnam Kazmi, I'm CEO of Asellus Ventures, and I have spent more than 30 years in the pharmaceutical and biotech industry working to bring innovative medicines to patients and also really looking at how to serve underserved populations better. In this panel, we're going to hear from some terrific speakers on topics such as the empowerment of women in healthcare decision-making, maternal health and well-being, and prevention and diagnosis of diseases that are particular to women. I think it's going to be a really terrific topic and panel discussion. Some of the things that we should be thinking of as we approach this topic is how is healthcare changing? So in the past, we would treat illness as something that needed to be fixed. We would go to the hospital when we were sick and have the problem taken care of. Now, and as we look to the future, things have changed. We're looking at really approaching and achieving wellness and preventing disease. We need to think about this as well in the context of women and women's health. Things like HPV screening, things like earlier detection of certain cancers, cardiac health. We know that women are often underdiagnosed and undertreated. And as we think about the future, we want to have women much more empowered and to be able to make good choices for themselves as well as their families. Also, we know that the pandemic has really accelerated the bringing of healthcare into the home. In the past, we would go to a hospital or a doctor's clinic. Now we're able to access healthcare advice remotely, and also, there's a big push towards education and being able to really understand, be more informed on how to attain wellness. We also need to think about mental health, and this is another important area for women. In the past, we concentrated on the physical health, but the pandemic has shown us that mental health is just as important for us to think about and act on. So we hope that you enjoy this panel. Thank you to the speakers who've agreed to be here today. It should be a very engaging dialogue. And my ask to you is, as you go forward in all of the things that you do, and especially pertaining to healthcare, think about health equity. Right now, the rich do well, the poor have very, very bad outcomes. We need to build in health equity and racial disparities thinking in all that we do, because it's not good enough to have the technologies. We need to be able to make sure that every single person can have access to all of the tools that will help them achieve better health outcomes. Thank you for having me here.
Thank you, Mrs. Shabna, for this interesting opening remarks. And health equity, as you mentioned, is very important. So before we dive into the topic, let me introduce now to our three guest speakers today. First, we have Anda Sapardan. Anda is a co-founder of Sehati, a mobile application in Bahasa to assist expecting mothers in monitoring their pregnancy through standardized guidance, and SehatiTeleCTG, a medical technology startup from Indonesia. Her passion and goals in life were driven by an equitable access to quality healthcare for women and children. Welcome, Anda.
Hi, Ravindra, thank you.
Our second speaker is Nihareika S. Singh. Nihareika is an international development and public health professional who has worked very closely on the issue of adolescent health and environmental health in emergency across South Asia, East Asia Pacific, and East Africa. Her experience and passion lies in using behavior change method for disease prevention, safe menstrual hygiene, clean water, safe sanitations, and early childhood development. Welcome, Nihareika.
Thank you so much, Ravindra. It's a pleasure to be joining you all today.
Last, we have Miss Stella Tan. Stella is a global health policy professional with experience working with UN organizations and NGOs advocating for sustainable financing and multi-sectorial action on non-communicable disease and gender and health across countries. Passionate about using innovative solutions to address gaps and achieve equitable access to health services in low-resource countries. Welcome, Stella.
Thank you very much for the introduction, Ravindra. It's an honor to be on a panel with such experts in this field.
Thank you, Stella. So let me start perhaps and dive directly into that third topic about women's health and start with UNDA. There is a statistic according to UNICEF who said maternal mortality refers to deaths due to complications from pregnancy or childbirth. From 2000 to 2017, the global maternal mortality ratio declined by 38%, from 340 deaths to 211 deaths per 100,000 live births, according to UN interagency estimates. In your respective countries, are you positive with those numbers and why? Thank you, Anda.
Yeah, thank you, Ravindra. Well, the facts in Indonesia is that the number is going ups and downs. Actually, in the year 2007, it was 228 per 100,000 live births, but it goes up in the year 2012 to 359, and then it goes down again to 305 by the year 2015. And afterward, there has not yet been numbers, formal numbers from the government about the numbers of the MMR. But I think with the COVID, it goes up because COVID has been the fifth reason of maternal mortality in Indonesia after hemorrhage, hypertension, infectious, and other diseases. And through the data by the year by data in 2017, that Indonesia is the third highest in ASEAN country for MMR. So with that, I think we have to, in many countries, I think we have to do non-business as usual measures to combat this, because it's our goal together in SDGs in SDGs, right? By the year 2030, we have to collaboratively together lower down the maternal mortality rate. So I am invited as the co-founder of Sehati and TeleCTG, and actually as Ravindra said earlier, that it comes from the passion of mine. And actually, our solution, SehatiTeleCTG, is a combination of digitization and IoMT, Internet of Medical Things. And we have proven to assist in lowering down MMR and MR in one of the regions that we do piloting. So in the year 2019, through our technology, we have assisted the local government to lower down MMR by 71% and NMR by 25.8%. And the sample is around 1,633 pregnant mothers throughout the year 2019. And it is because through the technology, through the data that we collected, and through the algorithm that is in the system, we can increase the early detection of risk factors by 88%, and we do early referral with that by it increases by 62%. So I think with technology you can do a lot. I mean, you can open access to equitable quality health, and it has and during COVID it has proven that our technology, because it can be operated remotely, it can be taken to the village level actually, where more people can have access. And we have, during the COVID, we have managed to assist in managing 42% of the maternal complication. So I think that's from me. In Indonesia, and non-business as usual measure has to be taken, I think, everywhere to achieve the SDG goal by the year 2030.
Yes. Thanks, Anda, for sharing this. And I agree. I think the impact of COVID has not been beneficial for that statistic, and also how your technological solutions can indeed contribute to this statement. How about you, Nihareika? We are very happy to hear from your thoughts.
Thank you so much, Ravindra, and thank you so much for this question. It's a very intriguing question, actually. So I think I can speak with regards to India, and I think with regards to India, we are witnessing a consistent drop in maternal mortality rates if you look at the recent National Family Health Survey numbers. And one thing that I would like to point out here, however, is that there are a lot of regional disparities when it comes to maternal mortality rate, because India being a huge country, given the scope of population and the regional disparities, every state every province in India is like a mini country of its own. So we have a few states like Jharkhand, Bihar, Uttar Pradesh, Rajasthan, Madhya Pradesh, who are not really consistent with the maternal mortality figures when it comes to the national level. And if India really wants to achieve its SDG targets of 2030 to achieve maternal mortality rate of 70, I think there is a shift that needs to take place on how we bring all these provincial outliers together, because there are various factors when I think about it. There's a continuum of care approach that we have to take. It's not just one thing that is going to contribute to maternal mortality decline. The longer the girls stay in school, evidence suggests that they marry late and they have fewer children. And also, evidence also suggests that women who start antenatal care registration during the first trimester of pregnancy itself are more healthy generally throughout their whole pregnancy duration and have fewer risk factors. And then there is also the factor that how many women are going for institutional deliveries. In India, you have tribal regions, you have people from minorities, and you have people living in slums. Do these women really have access to basic health services, and how easily and readily are they available to them? And most of these women are giving birth and undergoing labor in the home setting itself. So institutional delivery is also one thing that we have to look at. So I think the highest rate of maternal mortality when it comes to India is between this age group of 20 to 24, 25 to 29. And from my perspective, I think this challenge has to be looked from the continuum of care perspective. And I also think that it would be really interesting to see future research and evidence coming up that what happened during the time of COVID-19, because COVID-19 must have really given a hit to institutional deliveries. People were not really able to have those access to basic services, and also to antenatal care in Asha and A&M centers, as we say in India, in the rural areas. So what sort of hit did COVID-19 give to these services, and an associated impact on maternal mortality is something that we need to see in terms of future research. Thank you. I'll rest my remarks here.
Thank you, Nihareika. I think you mentioned within your country, India. I think it should be regarded with its specificities, and as you said, fragmented because different states, but also rural versus urban, and thirdly, I think the impact again of COVID also need to take in account in that analysis. So thanks for that. Now let's have some thought from Stella's perspective. Stella, the floor is yours.
Yeah, thank you. So I will speak in terms of Malaysia because it's my home country, and I understand the health and gender landscape much better. I would say for sure, I agree with the with the trend that Ravindra mentioned from UNICEF, and especially in terms in the Malaysian context. So we've seen a very significant decline in MMR And it was huge, from like 540 per 100,000 live births in the 1950s, to the latest figure would be 24.9 per 100,000 live births in 2020, which is an amazing achievement. And it really follows the trend as well, of developing countries, where the trend, you can see a steady decline. I mean, it plateaued over several years, but it has seen a steady decline, which is great. And I can sort of like highlight a couple of factors that I think, and also from research, that would contribute to this decline, which is an achievement in MMR in Malaysia. So first, I would say that the introduction of the rural health infrastructure, which is mainly constructing health centers and midwife clinics for the rural population. This has really greatly enhanced and increased accessibility and the availability of primary health care, and especially antenatal care for rural women. So this has like really closed the gap and increased the antenatal coverage for women to 98% in 2010. And I think I didn't have time to search, but I came across somewhere that, in 2020 or now it's almost like 100% coverage, which is fantastic. And there's also an increase in the average number of antenatal visits per woman. So this would be, from the public health care, which is from 6 visits in 1980 to 12 visits in 2010 for pregnant women. So along with the introduction of health centers, another main factor would be the introduction of specific programs to address the needs of women and children in Malaysia. I would also mention other factors, such as the increase in the number of safe deliveries by skilled personnel. I think this is very important. And the reduction in the number of deliveries by the traditional birth attendants. Of course, when we see in like rural areas, of course, we do see this occurrence. But I think there, the trend is that, it is reducing, and with an increase in safe deliveries. And but we always want to improve, right? So in terms of like, it's just relative in terms of comparison with other ASEAN countries. Malaysia is doing pretty well, but in terms of like the WHO region, Malaysia is in the Western Pacific region, which is WIPRO. So if we compare among Western Pacific regional countries, we are actually, doing relatively worse. For example, Singapore's MMR is around like, if we, compare across 2017 statistics, Singapore's MMR is just 8 per 100,000 live births. Ravindra will know, Malaysia and Singaporean was like 2. Healthy, I call it healthy competition. So which is like much, almost like 3.5 to 4 times lower than Malaysia. So fantastic, Singapore, and same for South Korea, was like 11 per 100,000 live births. New Zealand 9, Australia 6, Japan 5. So we still have a long way to go if we want to, Malaysia is almost considered a high income nation. So there's still a long way to go. So I just want to conclude and sum up this with that, in countries that provide everyone, not just, of course, with women and females with, but also everyone with safe, affordable, high quality health services, then women and baby can survive and thrive. So this is the power of universal health coverage. Thank you.
Thank you, Stella, for sharing all those statistics. I think it's always good to have those trends, especially per Asian countries, and we have such a very diverse panel from Indonesia to India and Malaysia. So now let's turn on the second questions, will be more generic and focus on economic empowerment and women's health. By definition, economic empowerment is to enable households to make their own decisions around making investment in health and education. Some health issues specific to women's health are breast cancer. We have also gynecological health, pregnancy issues, autoimmune disease, depressions, and anxiety among others. Let me ask you this question. For developing countries, what needs to be done to improve both economic empowerment and women's health from your perspective? I will start with Stella this time.
Thanks, Ravindra. I really like these questions. I'm really happy when you assigned me to start first. This is a really good question because economic empowerment and women's health, it's so, it really goes hand in hand. It's so tiny, you one affects the other. So in terms of economic empowerment and gender health, it's a power dynamic as well. And this power dynamic, because when you improve your economic standing and you improve your social economic status, then it changes the power dynamic, right? And this empowerment affect health-seeking behavior and outcomes among women, particularly rural communities. It really influences, women's. So I will go through a few factors. So economic empowerment and increased labor participation. It influences women's use of health services, for example, modern contraception, maternal and child health services. It also influences women's health literacy because health literacy ties to education level, social economic status as well. And it also influence health-seeking behavior and the availability and accessibility of health services. So this is just a little bit of explanation regarding the correlation between economic empowerment and gender health. So in terms of Malaysia, even among ASEAN countries, Malaysia actually has the third lowest female labor force participation rate at 55.2%, of women, of total women in the labor force, which is quite low. And, our government has always tried to, I know over the years, they've tried to come up with policies to increase, women's labor force participation. But it's very funny. It's very interesting to note that. But we have a reverse gender gap in school enrollment and education attainment because, it's been consistently found that women and girls, there has higher rate in school enrollment and education attainment. So we need to really understand and see, what is, even with such a high rate of women and girls in school and achieving tertiary education, what is holding them back from participating in the labor force, right? And also increasing, the number of women, with access to productive jobs as well. I would like to also, mention so in terms of this work, I think the World Bank, has done some in-depth analytical work in terms of the Malaysian context. So I think to answer the question. So for this question, I emphasize a bit more on the economic empowerment because, as mentioned, I already mentioned that the link between economy and women's health. So in terms of in the Malaysian context, I think it's really important to create better economic opportunities for women. For example, increasing investment in childcare. This is very, very important. This has to be front and center, in terms of improving women's labor force participation rate, and also providing incentives to encourage female labor force participation in terms of return to work policies, return to work incentives, enhancing efforts to revise the Employment Act to increase maternity leave. Before it was 60 days in the private sector, and now it's 98 days in the private sector. Introducing and increasing the paternity leave as well. from 3 to 7 days. Not a lot, but it's a start. And introducing new provisions on discrimination based on gender, for example, pregnancy at work, and improving protection against sexual harassment at work as well. So this would be my answer. And yeah.
Thank you, Stella, for sharing your thought. How about you, Anda?
Okay, very interesting. I come from a totally private sector, so I think I'm just going to discuss this from my point of view and from our experience working on the field.
Sure.
Well, it's significantly related to economic empowerment and women's health because, we are now familiar with the terms of my body, my own. My body is my own. And for that, you have to have the economic autonomy to be able to implement that, because otherwise you don't have the options, and that is what happened to many Indonesian women, I think. And well, during this pandemic, actually, it's very sad to know that early marriage is still happening in Indonesia a lot. And when we come to the field, and many students don't come back to schools. Many girls don't come back to schools because they have to. They are married during the COVID. So it started from the 12 years of age, I think. So I think for this, we come back to the theory of McCarthy and Main, where there are three determinants. Like the near determinants of the short determinants is the mother itself. So we really have to focus on them as the actors in this matter. And then the access to health facilities, I think it has to be increased in Indonesia, and I think with the health transformation that has been launched by our government, I think that would help. But the long determinant is that many other factors that needs to be addressed. It comes from the people, the community, the family itself, and even the regulatory. If you want to have autonomy on your body, then in Indonesia there are many factors that contribute to that autonomy. And one of them, I think the government can help by ensuring that there is a insurance or universal coverage or something that can help women to have that opportunity. Because, well, here many of Indonesian women are still it's the father, the husbands, the people, even the religious prominent figure, they still get involved in their lives, even when the mothers got pregnant and have a very high risk factors, whether they are going to be referred or not. It's not the women who has the say. Okay, I want to be referred, but there are many other actors that are involved in that decision. So I think for women to have economic empowerment, it's very 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 pivotal and very very important for to be able to have a good healthcare and good access to healthcare. And I think from my perspective as Indonesian, we still have to do a lot of things, and it involves many stakeholders for this. And I really do hope so that the strong commitment is there from all the stakeholders in Indonesia. I think that's my point of view.
Thank you, and I think equitable access to healthcare. Again, it's a very important point, and especially during that challenge that globally we are all still facing. I think that we're still seeing some mutations. I think that some countries may speak about another wave. So let's be positive. How about you, Nihareika? We'll be happy to hear your approach on this question.
Thanks so much, Ravindra. And I think I'm in complete agreement with remarks made by Stella and from my own perspective, I'd like to bring those two together because, India is a country where I feel, if not all, then probably more health disparities and social inequities exist. And, there are a range of issues here, but I think from where I see all of them is that from the perspective of India, I think the one thing that first and foremost that needs to be worked upon is changing of social norms, because Stella rightly said that these two things go hand in hand. From my perspective, if you don't educate a girl, how can she have the agency and choice to make those decisions for herself, whether she wants to have access to certain contraceptive services or not, basic things. And it's not even, and then it brings me to another case where it's not even whether the woman was educated or not. Even in urban centers, educated women are, I've come across cases where, after the pregnancy, without consent, the husband made the female undergo sterilization. So how do you have those choices? What are the various norms working layer beneath layer? It's not, now I've come to the realization when I come across both points made by Stella and Enda, that probably it's not even the access to education and access to health services. I think it's probably in a country like India, social norms, because very, very rightly said, these women are not just, trying to exercise agency in the family context against their husband. It's also the religious authorities. It's also the societal norms that are in place. And very interestingly, I was part of a research study on menstrual health and hygiene in a very remote district of Telangana in India, wherein we found that when there is a lack of menstrual absorbent, safe menstrual products in the school, and basic things like a clean functioning toilet and clean running water, the attendance level in the school of these girls dropped down. And as a result, they started dropping out, and as a result, there was an increase in child marriage cases in that district. And now we are thinking of how do we put the mother in place as, as this agent of change, but when she is herself not educated and aware enough about various disparities and various outcomes that her daughter can miss out on as a result of this child marriage. So I think the first function that we need to think about is how do you change those social norms at the very basic level of the society itself. So I think about this problem more in terms of behavior change, and of course in terms of raising the level of education, raising the number of girls who are attending school and college and universities. And of course at the workplace level itself, how many offices do we see having a separate area for breastfeeding? Not many, right? How do we make our workplaces more compliant towards various challenges that women undergo, whether it's nourishing their child during breastfeeding, or whether it's menstrual health and hygiene. So I think there are various levels and layers to it, but I think all of them start first and foremost with changing social norms first.
Thanks, Nihareika, to underline how social norms is important to take in account in those equation. So we still have 10 more minutes before ending the session. So for the next question, the third one, please, if you can be brief in your answer, that's why we can take an additional question perhaps from the participants. Thanks for that. Just so the third question is focused on disease prevention and control. Due to COVID-19, many habits for disease prevention have been taken, such as washing hands, and also about health in the food, and other also distanciations. What other measures shall we take to tackle, anticipate other disease, in particular in women's health, the topic of today? Nihareika, you might answer to this question briefly, please.
Thank you so much, Ravindra, and it's a pleasure. Thank you so much for sharing this question. I think, in my perspective, if you're talking about the range of diseases that women go through, um, and how can we tackle those through early prevention, I think again I'll iterate that early preventive behaviors are important, and also I feel there is a lot of understudied, under-researched areas when it comes to the various diseases that women go through, whether it is endometriosis or premenstrual disorders or postpartum depression and mental health disorders, or even perimenopausal mood disorders. So I think what I'm trying to suggest is that what bearing the very fact that these areas have been so under researched have on the current level of healthcare services and solutions that we have for these women. I'm also trying to probably note down here that it's the fact that while some of these disorders are currently under researched, it's also the lack of research in past lending to lack of body in the knowledge in the present. So I think from my perspective, it's important to bring more women into STEM fields, which also means that we have more non-male scientists asking relevant questions and coming up with novel research and solutions. So I think from the perspective of disease prevention and control, this is what I feel is important. Thank you.
Thank you, Nihareika. Stella, very briefly, please.
Yes. I will touch on NCDs, non-communicable diseases. So very quickly, we have found from research surveys that the pandemic has definitely impacted access to NCD health services in terms of cancers, diabetes, mental health, and a lot of the resources are directed towards COVID and infectious diseases. So for example, like also in terms of lifestyle changes, and because for example, physical activity is one of the risk factors for NCD deaths worldwide. But and also but because of like harmful gender norms, women and girls are generally have to in certain settings or environment, they limit their mobility. And in equal participation in physical activities. And also obesity in women as well, especially during pregnancy, also contributes to the health risk, not just for themselves and also for their children and family. So brief one. So, to overcome the challenges of NCDs, especially during the pandemic where, it has been, across, there's so much research that's been done that it has been, it became kind of like a collateral damage during COVID. So, that's why more emphasis, attention, investment, in NCDs, health issues need to be redirected, to women and, for all as well. Thanks.
Thank you, Stella. Anda, the last word for you.
Okay. I think for disease prevention and control, I think valid data is crucially important. I mean, for your health historical, your state at this stage, your risk factors and everything, and that can be used to predict, actually to prevent. I mean, like the very basic one first. I mean, you can use that as a basic data, and then you combine it with the genomic sequencing and everything, and then you can do actually predictive and prevention from that, and that could actually have impact in the health economics as well. I mean, like the health financing can be lowered down as well through good data, and with good data, I think you can design what kind of quality of human being you want to have in the future. I think from my side, what is important for disease prevention and control is valid data.
Yes, data, I think it's very, very important to take in account for disease prevention and control. And you do the perfect transition for my last personal questions, because I didn't find any question from the participant, and we still have 5 more minutes to talk about that final questions about this new trend that everyone heard about femtech. Is a term that refers to diagnostics tools, products, services, wearable, and software that use technology to address women health issues, such as menstrual health, reproductive health, sexual health, maternal health, and menopause. So perhaps, I know it will be hard, but in 1 sentence, 2 sentences, what will be some limitation to these new trends? Who might answer first?
If I may, I think it's
please, Anda.
I think it's ethics and regulation.
Yes, ethics and regulations, and it's one of those limitations. Data privacy,
Yes.
obviously.
Yeah.
How about you? Yes, please, Anda. You want to add something, Anda?
No, that's it from me. Thanks.
Oh, okay. Stella?
I'm on the other side of coin, which is, supporting femtech, being very innovative and very pro, digital innovation. So I think, from some of the research that I've done before, not digital health, but that I can translate to this, the limitation would be women living in urban areas, where they would have less access to internet and mobile phone connectivity compared to, women in rural areas have less access compared to women living in urban areas. Yes. And then it's also more straightforward to access women who are educated, and more, and more receptive to change, because, if we look at behavioral health theories, so that people, those who are more receptive to change, then they're more, willing to embrace, trying new digital technologies for health. Yes. So, thank you for the question.
Yes, I think
it's a great one.
More than geographical location, I think also digital infrastructures
yes.
might be limitations to this femtech trend. And how about you, Nihareika, the last sentence and word for this amazing sessions?
Thank you, Ravindra. I think from the perspective of my country, where 70% of the population lives in rural areas, I think it's a huge challenge and limitation to get that mobile phone and internet access in the hands of a young girl or young adolescent girl. If you're talking about femtech, I've been using menstrual hygiene apps myself, and I'm lucky. I was, developed part of the country. I was educated enough to use those. I think the biggest challenge that I see for my country is having that access in the young girl's hand itself of internet and mobile technologies, because during COVID-19 we have witnessed this. When education went online, these girls were in their households, and because it's a very patriarchal structure in India, most of the fathers were allowing only the sons to have use of the mobile phone, and most of these girls were not even able to attend their classes online. So I think again, there is a huge shift that needs to go in terms of social norms and change in country, and then access. So I think those are the two limitations that I see.
Excellent. Thanks, Nihareika, and we are coming already to an end. But again, thanks to all our participants today, our guest speakers, Nihareika, Stella, and Anda, for these engaging conversations, and our organizers, the Asian Network and area. For those who can, see you in a few minutes for our next and final sessions, Shifting Demographics and Lifestyle in Asia. Thank you.
Thank you all. Bye.
Thanks all. Bye.
Thank you so much. Bye-bye.
Bye.